Victor Dzau is the Chancellor of Health at the Duke Medical Center, and I think, Victor, from what I can tell, Duke is one of the most progressive and interesting medical establishments in the United States. And he's going to speak about world health and how we can learn from other institutions around the world, how they're delivering health care, et cetera. So I turn it over to you. Thank you very much for being here.
Well, first of all, thank you very much, and it's great to be here. I've always enjoyed coming to Aspen because, not only because it's an idyllic setting, but the meetings have just been terrific. A lot of interaction, a lot of learning. I know that I'm competing with Goldie Hawn and Deepak Chopra, and Peter Agri said, you know who your friends are. So it's a good thing we moved to a smaller room. Interesting subject. I'd like to begin my talk with a piece that was written in the New York Times last March. It's about a 62-year-old retired Bank of America executive. Now, he is, because he's just retired, he bought himself a high-deductible private health insurance policy, $10,000. And then he discovered he needed a double hernia repair. He did his homework. Instead of going to his nearby hospital, to Hopkins or to Duke, he actually went to Costa Rica. The cost was $4,000, and of course, that was substantial. He had a lot of substantial savings from that. And you say, well, we've heard this kind of story before. What's unique about this? Well, maybe not so, but it's a good starting point to think about the whole issue about how the external world is impacting our health in this country. For this individual, who's actually a former executive of one of the largest bank in this country, maybe not so large anymore, it's interesting to say that he's found in a no man's land between employment and Medicare. And secondly, it shows an individual behavior when you have to pay for it yourself, in this case in the form of deductible, you can look for the lowest cost possible. But I think what surprised me, of course, is Costa Rica, because Costa Rica, when I think about it, I think about the rainforest. Peter, you took a vacation there, in fact, with your family. And Duke has, in fact, a clinic that we run there to serve the underserved. And so you don't think about Costa Rica as a high-quality, affordable healthcare industry. And yet, that's the way it is, or it was in this case. So medical tourism, which is not the topic of my talk, however, has so many implications that is relevant to what I'm going to talk about today. I just want to give you one other example. In India, the Walcott Hospital is now doing open heart surgery, actually closed chest surgery, for $8,500. If you include travels and all that stuff, it's about $10,000 to $14,000, and that's a tenth of the price of what we pay in this country. And more importantly, these hospitals are recruiting U.S. physicians, and some hospitals, in fact, are founded by U.S. physician surgeons, and they're also going after accreditation. So we have an organization called J-Code that provides accreditation for hospitals to say, yes, you have the same standard U.S. hospital. Walcott Hospital have the JCI, the international arm of J-Code, accrediting as comparable level in U.S. And so I think if you put this into context, if I were a GM, I would say to my employees, here's an option. Here's an international option. Why don't you go and, in fact, get your surgery done there, and I'll save some money. And these things are happening because in Maine, the Hannaford supermarket is now offering an international option in the health plan. And Blue Cross Blue Shield of South Carolina, in fact, has now a subsidiary that offers international services. I think this is a wake-up call for us. If we sit and think, boy, we can really compete, and if the quality of the rest of the world improves substantially and quality metrics are harmonized across the world, where a hospital can actually say we have the same result as U.S., the only distinction we have would be a high price. So it's really important for us to think about, in this context, the global issue. Now, this is not only about cost. On service, it sounds like cost, but in fact, I think it's also about quality It's about access, about training. You think about who's staffing these hospitals, and are we having even reverse brain drain in this area? And of course, importantly, as to my theme of today's talk is, actually we can learn some things from the other countries. How can they deliver this kind of care with a much lower cost? So I'm going to talk about medicine around the world, and I'm not talking about Eastern versus Western medicine. I'm really talking about more healthcare around the world. And it's an important subject. It's an important subject to you, and you should care about this. Why? Because all of you who come to this meeting would all agree that, in fact, healthcare is, in fact, a social good, a human right, but also that it's the hottest subject we have right now in Washington, in our country. But this topic is so broad that I have to think about what are the aspects of this topic should I touch on, because it can potentially touch on cost, the way the care is delivered, global health disparities. 4 billion people in this world's population have poor health or poor access to health. It includes issues such as workforce training, challenges of course, a rapidly expanding market, commercialization, and many others. So what I thought I would do is, apropos to the invitation I got from Aspen and the little blurb they write, is to talk a little bit about two things. One is, what are academic institutions doing and how can we learn from our experience, in this case particularly Duke? And second, how can we take the knowledge that we can develop from innovators, in fact from developing countries, and maybe expand it, scale it, and actually impact the way we do health delivery in this country. So the messages I'd like to leave with you are, one, that medicine and healthcare are global. And in U.S., hospitals, academic centers, government ought to wake up to this, if they don't already have done so. And that what happens outside U.S. is going to have great impact here. So unlike the traditional way of the way we think, let's go and see if we can serve the under-resourced countries, and that's very important, I'll come back to that, and see what we can do in addressing the needs of people who are poor. Actually, it's a bidirectional and multidirectional opportunity. So therefore, in that context, in the postmodern era, as the blurb wrote about my talk, I think U.S. medical schools and health delivery systems should become globally oriented, engage in ways that advance innovation, education, student experience, research, collaborations, global health, and actually health delivery. And most important, the third point I want you to think about is the opportunity bidirectionally. It's not just us going out there to do good. It's actually, there's a lot of opportunity for us to bring back so we can improve our situation. So by bringing what we're good at abroad, we can also learn from what others are doing. And so while addressing global health disparities, we may be able to address our own healthcare system's shortcomings in this process. So let me start with my first point. And of course, everybody no doubt is familiar with Thomas Friedman's writing about the world is flat. Both developed and developing countries are more connected and share more common than any point in history. Telecommunications, information technology, they're making knowledge instant and egalitarian. And even highly specialized medical knowledges really are readily accessible to anybody in the globe with a few keystrokes. And of course, if you think about connectivity, you think about the rapid transmission of SARS, H1N1, and many other examples. In his essential book, Friedman says, quote, a triple convergence of new players on a new playing field, developing new processes and habits of horizontal collaboration that ensures the next generation of innovations will come from all over planet flat. And I think that applies to healthcare. There's a sea change happening everywhere in healthcare outside our country. And there are lots of issues which are philosophical and practical. And we are a little bit behind, unlike other industry, other economy, healthcare industry is behind. We've been essentially US-centric, really more looking at ourselves than looking outwards. So I think it's important now to consider the impact of globalization on everything that we do. For me and my institution, we have to ask the questions, what is the implication on education? How would it change medical school, nursing, and health provider education? What is our role, perhaps our responsibility, in preparing our students to address this enormous issue of health disparities globally? Can globalization open opportunities for research collaboration, translation, things which are becoming increasingly difficult in our country? And can we in some way, through our efforts, help set new standards globally in terms of the way the healthcare can be delivered, and then for global good and global adoption? Also, it's important not to think about globalization in negative terms, because I know in this economic circumstance, a lot of people think about buy America only. And of course, the issue here is, I think we have to take a long-term view as opportunities and concentrate what we do best and do more than previously thought possible through global collaborations. So you can see this talk, Medicine Around the World, is about the emergence of a healthcare political economy that is global in scope, connected, interdependent, unequal to be sure, but dynamic. It's about the opportunity for us to open our eyes to new partnerships, new ways of doing things, new sources of innovation, and new approaches to our problem. So let me address the second question, which is, how can a U.S. medical institution, particularly academic medical centers, play in this postmodern era? So my belief is U.S. academic entities have a lot to offer because we've always encouraged innovation. We've always encouraged disruptive thinking. We teach quality and ethics, which I'll come back to that later. And we serve really as an honest broker of research. That's what we can offer. By being able to take these kind of high value globally, we can actually set much higher standards and create opportunity for us as well. So first, I think we ought to think about extending our mission from U.S. to globally, from clinical care to global health, from research to translation, and teaching to innovative models of education. Expand our global footprint and teach others what we do best, which is life science and clinical research. Now, some people say that's risky because what you're doing is you're educating your competition. My own feeling is that we have to form this partnership early, because if we don't do so, we maybe one day will become irrelevant as others begin to pass us. So also, by looking at globally, we may secure additional sources of resource investment that can help us do the activities at home. Second, the overseas opportunities allow us to innovate in a whole variety of areas, which I'll give you some examples, in professional education, in care delivery, and in research. And particularly in research, when you think about global collaboration, a global endeavor, you could speed the translation of some of our discoveries back home into relevant treatments, diagnosis, and resulting perhaps even low cost and greater affordability. Finally, because we as academic institutions have an obligation to address global health disparities, we have a responsibility to do so and serve our long-term strategic interest. Now, global health is a discipline and area that has now blossomed. And a few years ago, when we began to create a Global Health Institute, there were only about 2 or 3 in this country, and now there must be more than 24 Global Health Institutes that actually, at a university level or at a medical school level, address the issue of health disparities. So I think everybody recognize that's an opportunity for academic centers, but also, as you know, it's really important for diplomacy. Certainly something that was not lost in the current administration in looking at improving maternal and child health in Afghanistan, And of course, we all know about PEPFAR and USAID. So I want to spend a few minutes, therefore, talking about our own experience. I think the critical issue is, what are we doing and what have we learned? Duke has always had a philosophy of making a difference in service to society. So several years ago, we rewrote our mission statement at Duke Medicine to reflect the importance of global health. And I'll read you just a brief quote. We strive to transform medicine and health locally and globally through innovative research, translation, education, but importantly, to improve community health and lead efforts to eliminate health inequalities. That's in our mission statement. It's a little different than most other medical centers where they talk about the tripartite mission. We're very clear that the importance is, in fact, addressing health inequalities. This statement means that we have to look at our organization somewhat differently, from very traditional disciplines of medical discipline to one that focuses on translation, community health, and global health. In that context, we have horizontally integrated the medical center in many different ways. We still have strong traditional departments, but we have created a translational institute, medicine institute, a center for community research, a global health institute, a support corporation called Duke Med Global or Asia, and several international public-private partnerships in Singapore, China, India, and elsewhere. So let me take a minute to talk about some of these areas, particularly what we learned from them. First, global health. Recruiting Mike Merson from Yale to head this initiative, we deliberately decided that this should be a university-wide effort, not public health, not medical school, but in fact, a university-wide effort. Why? Because we recognize the importance of environment, so the school environment is involved with it. We recognize the importance of engineering. We recognize the importance of law, policy, and we recognize, of course, the importance of so many other areas, including divinity. So we created a Global Health Institute that, in fact, involves everybody on campus. We now have activities in 15 different countries, in sub-Saharan Africa, in Asia, in the Americas, and elsewhere. But importantly is the students and the curriculum that's offered to undergraduate, not only for medical students and postdoctoral fellows. We now have, in fact, courses and concentrations, and we have a program called Duke Engage that allows any undergraduate student to have a semester overseas to do service and learning that is totally covered by the university. I think what's really interesting for me is comparable to my earlier experience with Paul Farmer back when I was at Harvard, where I created a division, and now it's called Global Health Equity, used to call social medicine, is the engagement of the young people and creating a whole generation of leaders who are actually going to follow this career pathway rather than trying to borrow their free time to do what they believe is good for globally. So I think this has been a major impact for us in learning about how important it is that this is not just a medical issue. As been pointed out, when you begin to address this, it's really an issue that's got to do with everything, including poverty, politics, and everything else. Also, we learned that we can leverage our pedagogical edge and to collaborate with other universities and also with other countries to do partnership. Because I feel that one of the things that's really unique to the United States, and I think as we contemplate our future and the place we play in it, is that we have some of the best research-intensive universities. I can say that unequivocally. So we should educate scientists, we should educate entrepreneurs, we should educate more physicians, but of the type that actually are leaders. So let me give you some numbers to make that argument, because there's emergence of many medical schools everywhere. But if you look at life sciences alone, McKinsey Global Institute did an analysis looking at the number of life sciences researchers, particularly in India and China. They argue, of course, people argue, that's going to be a growing area that's going to supersede and overtake, this area compared to the United States. So their analysis showed that there's 1.2 million young life science researchers combined between India and China. But when they judged them in terms of adequately qualified, using their criteria, 15% of these life science researchers were judged to be qualified. That means that there are about 150,000 qualified. In the United States, we have about 850,000 such researchers, and 80% of whom are qualified. So 700 versus 150. We have the edge. I think the message I give is that we ought to continue to be innovative and improve and develop outstanding pedagogical approaches to, in fact, seize the opportunity to develop more educational opportunity to develop, to train researchers. So our experience in Singapore is a good example. Because of what we do, when the Singapore government a few years ago decided they're going to create the multi-billion Biopolis, which is a major biotechnology initiative to drive the economy from a high-tech economy to a knowledge-based economy, they came to Duke and say, would we create a medical school with them, training mainly physician scientists. We're now in our third year of enrollment of students. We're now enrolling 50 students. Our target is to go to 100, 75, and then eventually to 100. And I think the experience has been enormously helpful to us because aside from the fact that actually creating a campus in a different part of the world and making this available, and we are providing joint degrees. And aside from the fact that we are actually drawing phenomenal quality students, the expats, I used to tell people that the chairman of board of trustees, actually Bob Steele, asked me, well, who are these students? I said, well, 30, 40 years ago, I was one of those from Hong Kong. I couldn't return because there was no postgraduate medical or graduate medical school. And now I think we draw a lot of outstanding students from everywhere. But importantly is the opportunity to innovate, because we have a blank canvas not only to take what we know best from Duke to Singapore, but actually to innovate the educational curriculum. Now, if you think about medical schools, in the first several years, most of the time the students are in classrooms, big classrooms, given a lot of information, and then they learn to regurgitate this and take an exam. What we did at the Singapore Medical School is actually a very different way of education. The students are divided into teams at the start of the year, and this team structure, of course, encourages collaboration rather than the rugged individualism. The teams are first given independent learning assignments prior to class. So each one is given the curriculum, they're given assignments, and then each class begins, before they even start, with a readiness assessment to see where the knowledge gaps are. Then when the teams begin to start the classes, they actually focus on how to close the knowledge gap together. And not only that, so it's a quick way of saying, how do we bring that information, knowledge to the right level? But they complete this learning in a team-based problem-solving approach. Now, in reality, and I'll talk about that later, I think education for medical school has to change quite substantially. We're going to meet the needs of, on one hand, healthcare delivery, and the other hand, the science and the physician scientists. That the current way of a single pathway and then eventually divergent much later is probably not the most effective way of doing things. So I think learning how to solve problems, not being able to memorize everything else, may be a very important way of education in the future. So this new model of medical education was written up in the International Herald Tribune last April. My senior vice chancellor, Sandy Williams, was traveling back from London, and he opened up Herald Tribune and said, whoa. And I think what they quoted appropriately was our Dean for Education, who says, this was only made possible because of blank canvas that we had to work with there. So changing the way we do things, this is going to influence how we do things back in Durham. Ed Buckley, the Dean of Education, wanted to introduce this method of teaching, which is really more broadly adopted in law schools and business schools, but had a lot of resistance. But I think frequently you're going to have to try to test this out in a different venue, and then being able to show the outcome, and then being able to innovate back home. So this takes me to talk about a broader issue about what we learn about education. As I said, I think that one has to really look at education, certainly healthcare education, somewhat differently in the future. We should continue to have these physician scientists training where we have leaders and people like Peter Agre and others who are going to make big differences in the world and with scientific innovation. But if one were to address the issue of healthcare delivery, we need a different type of training altogether. My own feeling is our medical students and our nurses and others are probably overtrained for the task, or many things they don't really use. That more focused training is probably more important in the future. Also, as you have heard many discussion about the need for teamwork, rather than the doctor-centric but a patient-centric approach, taking teams of people, nurses, physician assistants, pharmacists, etc., caring for a patient, and caring for a patient, let's say, in this case, globally as well, which we'll come back to. I think that education should be teamwork, collaborative, and maybe not school-centric. How do we get there is the issue. Well, we have been discussing with Mohammed Yunus of Grameen Health. He came to us to say, would you start a medical school like in Singapore? And I said, no, I think that would be the wrong thing to do, because Grameen Health, which is in Bangladesh, has about 50-some clinics, need a continual source of workforce. I think we should try to innovate and create a different type of educational paradigm in order to address the needs of workforce, and I'll come back to that later. So the other area of opportunity is clinical research, because as you know, so much of what we say that we take in medication, devices, require clinical trials. And more clinical trials are now gone overseas because of the cost issue and of course the fast enrollment, etc. And it is estimated by Boston Consulting Group that 30-40% of the global clinical trials in the next 5 years could be in India and China. In India alone, it would be a site for 15% of global clinical trials. That's a tenfold increase from today. Now, I would submit to you the quality. They do not have a critical mass of people, research nurses, statisticians, research personnel, in order to be able to meet all those demands. And of course, there's increasingly concern about the quality of the information that we receive from overseas. Let me give you an example. In an FDA audit of 16 major cardiovascular outcomes trial, 13 of the 16 trials, the treatment effect was disproportionately driven by non-U.S. sites than U.S. sites. In a very well-known study called the MERIT heart failure trial that shows that beta blockers treating heart failure reduces mortality by 31%, the benefit was entirely driven by non-U.S. sites. So what's the story? You can say, well, geographic differences, practice differences, genetic differences, but there's great concern about quality of the data, the quality of information which can be received from these areas. I think this is an opportunity for places like Duke, Hopkins, Cleveland Clinic, and others, where we carry out not only large-scale trials, but we have training for people with high-quality, site-based research. So we are now collaborating in China and in India, establishing training programs for these research expertise there. It draws upon our own rank of experienced investigators, collaborators. We already have such a program with NIH, in fact, a master's program. So my feeling is that that will all allow us to train much more quality scientists and researchers and research nurse and personnel, but also allow us to begin to set up our own network of research overseas, but also, of course, also help to be assured that the data collected are done by people who are accredited. I think this is have great implications in terms of drug efficacy and safety worldwide. To quote the former U.S. Treasury Secretary Paulson, he says, quote, "This is not an issue where you can inspect your way out of it. quality has to be built in. So I think this is an opportunity for U.S. universities to play a very important role, to train this, but also enable to extend our research. Another area, of course, is that although we have a, quote, broken healthcare delivery system in this country, there are lots of pockets where integrated healthcare delivery is successful. That is from primary care to secondary care to tertiary care. And there are other areas in which an integrated system, instead of multiple hospitals, are integrated not only by information technology, but by management structures. So we're working in China with the Peking University Health Science Center. They have 8 different hospitals under one roof, but they function totally independently. So part of our effort is to help them at least look through the Duke model of integration and also developing, in fact, management programs for health sector management, etc. So let me move to the last part of my talk, which is transitioning from all those experiences in terms of how does it matter to today's issue of healthcare reform. And of course, if you things work out in healthcare reform, 2009 become one of those obligatory entries on the high school calendar that says, American history, along with Medicare 1965 and Social Security 1935. The problem is, is cost. The problem is coverage. I think much of the discussion, as you hear at this meeting, so far healthcare reform is talking about economic and maybe insurance reform. How are we going to make a difference in the delivery of quality? I think this is, in fact, an issue, a more effective delivery system. A delivery system which is effective is very complicated, probably the most complicated issue of all the healthcare reform because it involves skilled workforce, training, infrastructure, organization, information technology, safety, quality, access. I think there would be, and there's the emergence of a thing called delivery science, a way by which people begin to look at what's the best way to deliver healthcare in the most effective way. And how do you incorporate the best practices in the world so that we can learn from the innovators around the world as well as ourselves. So this is, in fact, the thesis that we got interested in this question. The thesis is by looking at healthcare innovations around the developing countries, countries that have limited resources, countries where do not have inadequate finance, big distances in delivering care, transportation problems, workforce shortages. Many of these countries have pushed innovators to solve their problem, to be creative and resourceful, and to deliver care at a much lower cost. Now, many of these are individual one-off innovations, which I'll talk about. But the entrepreneurs, actually Bill Hazelton been very much involved with this, has looked at using mobile phones, using other handheld portable technology, looking at focused training, and also franchising and socially based risk pooling, and many other approaches. These are well worthwhile studying, in my opinion, because when we learn this, not only would we be able to help different countries which are under-resourced to adopt each other's approaches, but maybe we can bring something back to this country as well. So I'd like to tell you about a project that we're doing with the World Economic Forum that Duke is leading together with Pfizer, and it's called Diffusing Innovation in Global Healthcare Delivery. And it's conducted under the auspices of the World Economic Forum with Duke and Pfizer. And AstraZeneca, Aetna, and Cisco are also partners of this group that we're working on. The project explores how to take stakeholders from developed and developing countries, and that means some of these innovators, entrepreneurs in emerging markets, large companies, NGOs, policymakers together to say, how can we learn from the efforts of these innovation everywhere? And how can we bring together these innovation so that we can contribute in a more coordinated fashion the creation of a sustainable healthcare delivery models in some of the world's poorest areas, and perhaps can influence U.S. as well. Now, so the thesis is that systematically identifying, documenting, sharing, and supporting these innovative solutions which successfully deliver care to the poor, the under-resourced, what C.K. Preloud calls the bottom of the pyramid, has the potential to transform global healthcare and markets, and of course can help us as well. Now, why World Economic Forum? Because it's got to be scalable. It needs the collaboration of industry. Because so far, NGOs and governments have great difficulty with resource and, in fact, the ability to mobilize infrastructure. We believe that if we can get industry interested, arguing that, and I'll come back to that, that this is a much larger market in changing the business model of today of high price, small market, US and Western centric, to a lower price point, but a much larger market globally, you can do good and do well as well. So that's the project that we're looking at. So the question, of course, is, when you talk to industry leaders about this, they say, well, can they afford what we're selling? And, as C.K. Preloud and Muhammad Yunus have noted and demonstrated, the world's poor have a tremendous buying power. They call the bottom pyramid. And using what they call the purchase power parity, there's a kind of formula that you can do. Actually, there's about $4 trillion market in the bottom of the pyramid. And if you ever had a chance to read C.K. Preloud's book, that is articulated very clearly about how these people actually purchase, but they're a lot more careful what they purchase. They want quality at low price. But that is a real substantial market. My own feeling is, if this can become a market for industry, we'll be doing good, because therefore we can create that kind of market and being able to deliver the healthcare that's needed. So it shifts the whole idea of a high price point market to one of a low price point, a much larger market. So Bill Gates said it best in the World Economic Forum in Davos in 2008, quote, government and philanthropy channels are caring for those who can't pay, but this is really not sustainable. But to provide rapid improvement for the poor, we need a system that draws in innovators and businesses in a far better way than we do today. Such a system would have twin mission, making profits, but also improving the lives of those who don't fully benefit from today's market forces. So that's the point. So he calls it creative capitalism. And he's not alone in this thinking, because Muhammad Yunus of Grameen Bank has called this social business. It's an entire field of approaching this, going beyond social entrepreneurialism in doing business that's socially important. And I think this has emerged in the last decade or so. And I'd like to particularly highlight an excerpt from the line from Bill Gates that I just read. And I said, a system that draws in innovators and business in a far better way than we do today. Well, let's replace business and innovators with healthcare, a way to drive healthcare in a far better way we do today. So let's take a look at how do we find these ways to merge these issues. Well, if you look at the similarities and differences and challenges in care delivery between developed and developing country, you find that we all want the same thing, which is access, affordability, and quality. This is what President Obama talks about. This is what we want. This is what everybody wants. But the difference is, in developed countries, we are finding it difficult to deliver all three. We can deliver two, but not all three. And simultaneously, and every country is struggling with this problem. Peter Orszag says that, in fact, entitlement of healthcare spending as the single greatest threat to long-term solvency of the U.S. government. So I think that if all of you read the New Yorker article from Atal Gawande, which points out the great variability in terms of the cost of care everywhere, and he pointed out the overuse of high technology procedures, such as explaining differences between the healthcare spending between McAllen, Texas, and nearby El Paso. So people are saying it's almost impossible now to think about achieving all these three. Yes, impossible if we continue to practice the way we practice medicine today. Because if you were to juxtapose what's happening in developing countries, they have the same problem. But their issues are so much related to the high burden of disease, poverty, and the lack of workforce. And so I think there's a critical need for both developing and developed countries to look at innovation as a way to solve the problem. And the innovation here is not in technology only, but delivery innovation. Because in our countries, innovation is usually high tech, therefore high cost for diagnostic treatment, whereas in developing economies, more and more innovation actually is providing care of people at the bottom pyramid. And this is where I'd like to give you a few examples. And again, I want to recognize that Bill Hazeltine is actually very active in this area as well. So here's two examples. Health Store Foundation, or the CFW shops in Kenya and Rwanda. This foundation turns nurses and other community workers into franchise owners of small, focused outlets addressing the four leading causes of morbidity and mortality in their community, which is, especially in children, malaria, respiratory infection, diarrheal disease, and worm-related diseases. The franchisees offer therapies and intervention, including medicine supplied through the CFW shops, for which they are specifically trained. And this expands the reach of existing workers, recruits new workers, and provide a novel self-sustaining franchise model as a vehicle. In India, the CARE Foundation, the CARE Hospital Group, which was started in 1997 with a single hospital by a group of Indian physicians. In fact, they were concerned about the lack of forward movement by government-based hospitals. So they created this hospital desiring to care for the India's underserved. Today, they have a network of 12 hospitals and is evolving a hospital chain to an integrated healthcare delivery system. They also form a nonprofit foundation arm, and it aims to address access issue in rural villages through a hub and spoke model with a combination of de-skilling, portable diagnostic, and telemedicine. They also aim to make existing infrastructure, that is, existing clinics, and off-the-shelf technology, a handheld simputer they have, wherever possible, and create public-private partnership, now with the state of Andhra Pradesh, beginning with pilot projects. These are only two examples, and I'm sure many of you, through our conversation, can see many different innovative examples. In fact, the Wall Street Journal recently profiled an example of an AIDS clinic that, in fact, that University of Alabama borrowed from an AIDS treatment program in Zambia to reinvent the way new patients enter the clinic and drop its no-show rate for the first time in half. So there's a lot we can learn. Our question, when we get this group together, is to say, how can we actually first have an inventory and being able to evaluate the scalability and the transferability of some of these innovation? How do we get the right stakeholders together to say we would like to adopt them and try them in our country as well? And how do you get funding for all this? And how perhaps through measurements and metrics demonstrate the success whereby we can actually make it compelling in our own country as well. So when we approached this, we had the core team, which is Duke, Pfizer, and World Economic Forum, and we've now included Rockefeller, Results for Development, Robert Wood Johnson, Gates, and others. And I mentioned also the industry partners as well. McKinsey is now working on a pro bono basis to, in fact, to create an analytic framework, an inventory for understanding, evaluating all these innovations. So the first thing we're going to end up would be a knowledge product, a product whereby we can be able to see what is going on as a network about, and how do you measure these innovations. And in fact, our questions are they game-changing? Are they sustainable? Is it scalable? Is it transferable? Is it even tradable? So those are some of the questions that we're asking. And since the 2008 Davos meeting, which I presented this concept, we have moved along quite nicely. And it will be, in fact, as an agenda for the Healthcare Board of Governors at the World Economic Forum in January 2010. So as we proceed, we want to get more and more stakeholders involved, particularly government and policymakers, because at the end, these cannot be sustaining without the participatory government. But I think we have to get industry being able to say, yes, we are putting our resources behind it too, because we believe it's good for everybody, including the expansion of the market. So my hope is that to connect in-country innovators, private and public partners, both domestic and global, create an active, what I call I2G, innovation to globe network for exchange and learning. And of course, ultimately, we'd like to adopt and implement. We now begin to think about funding for this as well. It's possible to create a fund, particularly trying to get industry and others together to look at funds that can support such a program. And again, government will be very important. Now, it's interesting to think about these innovations. I mean, will we cross an area of intellectual property issues? So we have to begin to address this as well, right? So the argument is that these innovations are meant to create better roads to villages and markets. In other words, the industry should not see them as protective of their innovation, but in fact a sharing innovation which can expand the market for them as well if everybody's willing to share. So that's another area that we have to look at. But importantly, we want to measure outcomes. The outcomes have to be measured in systematic fashion every time we're going to do these projects, which will be cost and, of course, health outcomes. And because this is, of course, very important to make a compelling case, not only to have any of these innovations adopted in any country, but perhaps we'll have a way to bring them back to the United States. Perhaps establishing a fair trade in these innovations could be one route to the ultimate sustainability. So I'd like to conclude now by just simply saying that I believe that there's a tremendous amount of opportunities as well as challenges in the area of global health, global medicine, and that institutions like Duke and other academic institutions can spur a transformation of medicine and the advent of global medicine, and that collaborative public-private partnership and projects such as the World Economic Forum can allow people to work together to a more coordinated fashion, to enter partnerships with government, NGOs, etc., so that we can ultimately contribute to much better health globally. So I hope that we'll be able to also bring back some of this disruptive innovation to this country. Thank you very much for your attention. Do you have time for questions? All right. Michelle.
Well, so you've started this new medical school in Singapore, which is an incredible facility. And I'm just wondering, you're getting close to your first class graduating?
They are now in the third year.
Okay. Do you have a sense of where they're going to end up?
Yes.
Are they going to stay in the region, come to the States?
That's a great question. Actually, you know, the question is, since they are now entering the third year, and they will be graduating another year or so, actually in 2 years, they're entering the third year, do I have a sense where they're going to end up doing and where they're going to end up training? And this is really a very interesting, I guess, unplanned consequence. When we began to do this, it became very, very quickly, when we look at students' recruitment, was that the issue of where we're going to train. The Singapore government gave a service, what they call a bond, which is that, you know, you have to, in fact, pay back to Singapore if you get a, scholarship. So that created a lot of discussion about what that really means. And also, because there are people who, in fact, train in the U.S. want to go back to U.S. for training. So we entered a whole series of very extensive discussion. And long and short is that it's possible to get a waiver for the training period, and that U.S. training is certainly acceptable. But what the interesting part, of course, is that the current graduate medical education in Singapore is very different from U.S. So it's more like a UK graduate medical education. That actually spawned the Singapore Minister of Health and Education to relook at the GME altogether. And so they did get the ACGME and the boards to visit them. And after an extensive analysis where they pointed out, in fact, many defects of the current program, they're actually moving towards a US-like graduate medical education, which actually enable our students not only get the comparable experience during the student period, but also being able to, in fact, come to the United States. I looked at the first class, which is only 25, entering the third year, there are 4 students who's coming to Duke to do research, because as you know, our 3rd year is a research year. There are others who are doing different types of research. So I think the opportunity for actually collaboration and exchange is very substantial. Yes?
Thank you so much for what you offered. I was glad that you mentioned Paul Farmer, and probably people know about his commitment to liberation theology, which is preferential option for the poor. And not only in terms of treatment, but also in terms of listening first to the poor and the disenfranchised for input. So they're not only objects of treatment. So the question that I have is, you at the very end talked about criteria for assessing these initiatives, and you talked about game-changing and sustainable and other lists. I'm particularly interested in game-changing. Our institute is also interested in innovation, but we've seen, we've tracked that as innovation comes, whether on the local or global level, there's also a tendency for predatory, opportunistic practices to happen around that. And we see it on the local and the global level. We've coined the word global to be a composite of global and local, meaning we all know the elephant in the room is that healthcare has attracted a lot of predators that make use of it. Not in the very beginning, in the entrepreneurial moments, but after a while. I mean, I have so many instances I can cite that something gets perverted from its initial socially beneficial attempt into something that is completely against the very people who innovated it and the very people it was meant to serve. So we have always looked at whether innovations can be placed in such a way that they can protect themselves from predatory practices, which I won't exactly specify what I mean, but maybe you're understanding what I'm saying. How do you think about that?
I think you raised such a very important point. On the first point, in listening, I think it has to go well beyond health. This is why I think, the ability to engage a lot of other people, really you're looking at their entire, livelihood and how it affects health. On the second point, I think I'd love to get you involved with this, because I think we're just beginning to look at, with the help of McKinsey and then gathering all this information, what would be considered. We still have yet to describe and determine criteria of game-changing, but the kind of concern that you have has to be part and parcel of this consideration. Thank you. Yes.
I think it makes me, I don't know why, but a little bit nervous with the tight partnerships with industry. And I think partly because of, what for me has been a growing cynicism about the role industry has played in how we care for people in this country, with pharmaceuticals in particular, but technology that really drives up costs with not very much added value. And so, while it seems clear that having industry partner for high-value drugs like anti-HIV meds or antimalarials that have a real small number needed to treat to benefit makes sense.
Yes.
How, I guess I see this sort of specter of industry getting their hands in and suddenly bringing in, a huge
Yes.
market for a lot of low-value.
Well, first, I would say that I think almost all industry is recognizing that current model is not sustainable. The real question, as in everything else, is how do you make the transition to one model to the other? So I know for a fact that Pfizer and others have now new divisions called global markets, where their focus is not just looking at, global market is Canada, Brazil, Russia, etc., but looking at these markets which are in developing countries and trying to understand how they can work on it in the future. So there, I think from a strategic viewpoint, I believe, and Lisa's here, maybe she can speak up, I believe that a lot of companies are well aware they've got to change the model. The question is how. I think this is giving them an opportunity to work together to think through this. And in fact, I know that Pfizer's already got a whole collaboration with Muhammad Yunus and the Green Bank. They have on ground a whole number of people whose main job is to study and become fellows or whatever to learn how to do this. And I think other industry, including GE, etc., also begin to focus on this. I think it's reality because I don't think it's possible, at least in my mind, just to get government to say we're going to wake up tomorrow and to say, good work, we're just going to do it. And it's constrained by all the other areas, and NGOs likewise. So we don't involve everybody. An industry, my feeling, has the largest infrastructure globally and has the ability to do this. It's my hope, maybe naive, that they can see the quality and the opportunity for this. And so far, I think a lot of people are interested. We've got AstraZeneca at the table. We have, as I said, Pfizer and others to the table. So I don't know. I guess right now, in this early phase, it's more planning, evaluation, and ask the question, and then have them get involved with all these things as we begin to think about what the next steps are. I'll be interested in hearing, Lisa, perhaps your response to this.
In truth, it does have to be a partnership because it's pretty difficult for industry to do it without government or government to do it without industry because somebody has to be investing in terms of getting the actual medicines, the healthcare systems. It's just a very expensive thing to do. At the same time, there is a realization that it can't quite go on the way that it has. Fundamentally, there is a belief that what we and everybody in the healthcare system does, the biggest success is actually improving health. And that's a measure. It pretty much has to be. Because if it's not, you won't make it through regulatory issues, you won't make it through government, you won't make it through anything else. So the question does become, what is the right balance and how can we truly treat it in a way that's incentive well? The other thing that we all have to think about and work on is, in addition to kind of like the private-public partnership, what is the role, what is the desire for individuals? And what role do they want to play in health decisions? What's going to drive it, behaviors, and all that. So it's really about how we're going to kind of change the dynamic. And I think I can understand in all candor, some of the concerns that have gone on in the past. And I think that there is some, I think they will admit that some things probably could have been done a little differently, a little better in the past. But saying that, as we continue to move through, there is a willingness to do it and do it the right way such that everybody can.
There are some examples, and I think Bill may have them. For example, Beckman Dickinson. They've developed a CD4 count and a really much lower cost, and they've actually have a several $1 million business that enable to develop. So I guess the changes have to be, manufacturing has to be different, marketing is different, they have to take the price way down there versus using a US model. That's probably why people would be interested, begin to explore, is that possible? Bill?
Yeah, to this point, part of the way of looking at the industry is, should existing healthcare industries that serve developed countries also serve these markets? And there's a big disconnect between how they behave, how they price, how they do research, and the products they develop. On the other hand, there is a very rapidly developing industry in the developing countries themselves that is geared entirely differently. For example, look at the API and generic manufacturing that were responsible for lowering the cost of AIDS drugs. It wasn't the U.S. companies that did that. It was local companies in India mostly that did it. Same thing for medical supplies. We pay a fortune for medical supplies. We don't have to. There are ways to produce medical supplies that are much, much cheaper than the sort of semi-monopoly that currently exists. So I think by integrating not just the leading companies in medical supply, medical equipment, pharmaceutical in the West, but beginning to integrate the productive capacities of the developing countries, we can make a big difference because they are really oriented differently. And it is going to be a big challenge to see if it's possible at all for a Pfizer or one of these large companies to play in this field. It's not obvious that it's going to happen.
I think you've got a very good point. We just have to learn it. Other questions? Yes, Kitty.
I was really intrigued when you said that maybe we're teaching students more than they need to know, that we're not focusing enough on what they might be good at, or I just wanted you to elaborate on that a little bit, only because I teamwork, and that that's going to become the workplace of the future, it begs the question for me, what happens to true expertise? And when I go down the street to my internist, do I want her thinking about global delivery systems and collaborating with business people and engineers in her mindset, or do I really want her to know that, in fact, I've got a hole in my heart? So I'm just curious, when you attract these students, how do you focus their development of depth in a field and also their capacity for innovation?
My feeling is that if we're going to really transform medicine, we have to go back and relook at our educational paradigm. I mean, people talk about the next Flexner report, and we have not been able to get there, right? But I would put it this way. The big debate right now is physician shortage in primary care. And AAMC says we need to train, 30% more graduates. I think it's difficult to sustain that, principally because the cost to train the number of physicians and the continuing increase in demand. So I think a very important way of looking at it, which is the emergence of the whole idea of team-based approach, medical homes, is to say, look, not everything has to be only a physician only. I think Mehmet also talked about questions about solution factory versus, right? But I think that makes a lot of sense. That means that we have to start thinking about how we train our students. So what are we trying to train our students for? One is we want to train our students to be physicians, practicing physicians. They're going to be working in an environment of teamwork in order to meet the demands, the work demands. We want to train our students to be physician scientists. That's a different pathway. Currently what we do is we actually put them through the same thing over 4 years before we allow them to differentiate. And you spend a lot of time learning things that you may or may not use. I'm not trying to get beyond this general comment because it's a slippery slope when we get into detail, and Daryl's here, so he can, President of AAMC can talk about this. But my own feeling is we got to look at giving people the right skill set and more focus in delivering the skill set that they need for the purpose, rather than giving them too big a campus and then trying to reorder them to, So if you think about the global delivery, people have learned to use community workers, nurses, and others to be more focused on the care that they give. And I think we have to begin to think about the same thing in order to solve the healthcare issue. Right? So that's really what I'm talking about. So if you think about this, learning in delivering of care, particularly if we're going to do more medical home connected care, would be learning how to work in teams. So rather than the traditional curriculum, we really ought to be bringing, first they have their own curriculum, but bringing people together very early to learn how to work as teams, to look at how, in fact, the patient who wants to access healthcare could take any one of the person on the list as the primary giver with a physician in the, who could be, say, the physician leader of the team. The Macy Foundation is having a conference and a task force, which I'm co-chairing in January, called Who Will Deliver the Primary Care of the Future and How Do We Train Them? You can imagine the kind of people that come together to talk about this. Jerry, you want to expand on any of the things I want to talk about?
I think the stunning change in medical education has been, when we went to medical school, we had this illusion that we could accumulate enough facts to be a capable expert. And we've now finally reached the point where we realize no human brain can hold the number of relevant facts to be an expert practitioner. And the question now is, how do you train somebody to handle vast amounts of information in the service of the task in front of them? This not only is changing the way we're educating, but it's changing the way we assess. The traditional testing, everywhere from the MCAT to board certification, was based on knowledge accumulation. The real transition now is testing assessment for competence. And the physician scientist will need to prove their competence to handle laboratory problems. Your internist will need to progressively prove competence and mastery in identifying problems like a hole in the heart. So it's a major transformation unlike my generation, incoming medical students, nursing students, and others are very comfortable handling vast amounts of data. So it's a transition that's kind of been going on under the radar. It really is transformation.
I think aside from the methodology of pedagogical approaches, we may have to begin to think about maybe early separation of tracks, and not really to do a single track and then begin to divide them, depending on the person's, what's the word I'm thinking about, choice, if you will, in terms of what they want to do. And that may be one way to, because I think what our problem is, to be honest with you, a lot of issues are regulatory, accreditation, right? You can't have a student graduate without having checked off all these things. You can't have somebody who finished internal medicine without saying you have to have not only competency, but you've done all these things. But some of them are not absolutely necessary in the issue of looking at what you want to do for healthcare. So I think there's a lot of these issues involved.
Victor, are you thinking about two different types of medical schools? It sounds like you're
I
really...
was trying to avoid getting so specific.
That's what it sounds like. It sounds like you're going to have a medical school that's integrated with an academic research
Well,
center.
let me put it this way. Duke
and,
has...
And another kind of medical school that turns out doctors for primary care or global health.
Yeah.
And maybe they both have to work in teams. So that part would be...
I'm doing a lot of thinking right now about this.
Yeah, it really sounds pretty revolutionary.
But because Duke's curriculum, for example, is known to be, getting physician scientists. But since I care so much about primary care, I've thought a lot about. So I've actually gone together our nursing school, our medical school, PT school, and talk about how we can create an interesting curriculum in the context of today's curriculum. But I think whether your suggestion about, I don't want to take away our real strength of what we do. I mean, we have Michelle, got an MD, PhD from us. There's some really phenomenal people who've been trained. The question is, how do we meet today's healthcare demands at the same time being able to produce the kind of people that we want? I think you had a question, and then, yeah.
Okay. So I sit on an interagency federal White House working group looking at innovation and information policy, and we're now developing a group within HHS to look at innovation policy. We're doing a lot of really interesting things. The question, how might we involve policymakers, and specifically HHS, in encouraging the kind of innovation we talked about in medical education and translational research? It's a huge question, but...
It's a huge question. Any ideas?
Oh, you're already involved.
It's funny because Bob Kocher called me the other day and says, your stuff about education, we're not hearing enough in the White House. I want to hear some more about this because nobody's, with all the people that we're talking to, nobody's spending enough time talking about how do you actually educate the workforce of the future.
Right.
So yes, absolutely. I would love to talk to you and see what you think. Okay? Yes, I think Malcolm has a question. Yeah.
I didn't really have a question, more so kind of experiential. I want to just share the experience of being actually in this curriculum.
That's right. Maddox is one of our MBA students at Duke.
So kind of going back to the question of being an expert in the area. First year curriculum, and I finished in 2002. You just get, it's kind of overwhelming in the amount of information that you get because it comes from so many different areas and there's so many different topics that you're experiencing in the medical arena. And so I think I was talking with Dr. Buckley once, and I think that the ultimate goal is for us as students to be able to use our resources because you organically start to look for resources outside of the information agency in a way that, so alternative resources are synthesize the information in a way that you can digest it and process it and be able to articulate it on an examination. And so I think that what I hope, or what I think that they're trying to do is provide us with the ability, or train us in a way in which we can, maybe we don't know the answer off the top of our head because there's just so much information to know, and it's not necessarily in our head, but if I had a question, I can know exactly where I need to go in order to find the answer, or who I need to consult, who might be a better expert in the area, so that I can better help the patient that has a problem that I may not necessarily be best able to address.
I'm told that I should end this meeting because we have another session. So I'll be happy to speak to anyone.